honorable faculty and MRCP Part 1 aspirants. Our today's class topic is about endocrinology, and our speaker for today's class is Dr. Gautam Das. Yes, sir. Thank you, sir, for taking out your precious time for this class. Welcome to this class.
My name is Dr. Gautam Das. I work as a consultant in endocrine now in the Imperial College Diabetes Center, London, in Abu Dhabi at the moment. I have recently moved from the UK after being there for 19 years, and I've been here only for the last 3 months. But wherever we go, we do the same subject. Patients are the same. So I haven't changed, and my association with Farz hasn't changed. So, okay, so I'm going to give you a flavor about Part 1 MRCP again. I think I've done this multiple times. Some of you will know me, some of you will not know me, but what we do here is in a question and answer format. I read through the questions, highlight the issues that may be in the questions. But this is not an exam, right? So it is just to make you understand where exactly you are looking, what are the pitfalls in the question, and how to formulate an answer, and which will be the theme probably for every subject that you do when you prepare for MRCP. Questions are a bit descriptive, but the answers are fairly small, and every answer may be followed or may not be followed with a very small explanation. And if anybody has any questions in between, you can stop me and you can ask me questions. So let me start. The first question, this is a 25-year-old lady who presented with a 6-year history of hirsutism, having noticed dark coarse hair under her chin. Being a tour guide in a tourism company, these symptoms have been very embarrassing and distressing for her. So she has tried local measures like shaving and applying depilatory creams, but without much success. Her periods have been irregular, which are usually oligomenoric. She attained menarche at the age of 13 years. So initial periods were okay, but currently her periods have been irregular and she has got hirsutism, which is quite distressing for her. She has not yet conceived or become pregnant. On examination, she had a body mass index of 25 kg per meter square. She had coarse dark hair overlying her chin, lower back and inner thighs. She did not have any galacturia to expression. Now, a set of blood tests were done in the follicular phase of her menstrual cycle, which would suggest the following. So you can see and have a look, quick eyeball, and then I'll go through it. So you can see this is mostly the androgen profile we do to explore hirsutism in a female. This lady has got slightly raised androstenedione, slightly raised, or rather borderline raised dehydroepiandrosterone sulfate. 17-hydroxyprogesterone is normal. Estradiol for the first half of the cycle is okay. Serum testosterone is elevated, so 3.8. Sex hormone binding globulin is slightly low. Plasma LH and FH is okay. And prolactin is just elevated. So which one of the following is the most appropriate treatment for hirsutism and her underlying condition? Whether it is metformin, whether it is cabergoline, whether it is bromocriptine, whether it is clomiphene citrate, or whether it is an oral contraceptive pill. So you can make a choice for yourself, write in your notebook, and then you can compare to see whether you got the answer correct or not. Okay. So this person has got hirsutism, has got irregular menstrual habits, and she has got raised androgen parameters, which are commonly estimated. Prolactin is not so high. So answer here is E, which is oral contraceptive. Yeah, where it is gone. So the answer here is E, which is the contraceptive pill. That is by far the best treatment, because the diagnosis is very clear here. This lady has got polycystic ovarian syndrome. So the most appropriate treatment for this lady is polycystic ovarian syndrome. She has got a BMI of 25 and above, which is just overweight. She has got hyperandrogenic features, and then she also got menstrual irregularities. So if your patient is not contemplating pregnancy, then the best treatment would be oral contraceptive pills to suppress the effect of androgens or testosterone. But if they are contemplating pregnancy, then your aim of treatment should be to lower the insulin resistance. And in those circumstances, the first line of treatment will be metformin. So the most appropriate treatment here is oral contraceptive pills. And traditionally, it is usually a combination of ethylene estradiol with cyproterone. Cyproterone is a progesterone which has got anti-testosterone property. And other common preparations are ethylene estradiol, which is combined with drospirenone and that again has got anti-testosterone property. So it is essentially a combination of estrogen and progesterone, because this not only will suppress the hyperandrogenic features, but it will also allow to regularize the cycle. So the person will have withdrawal bleed because of the progesterone. So it will be a monthly cycle. How does the contraceptive does its job? It principally reduces the LH surge. It also reduces production of androgen from the ovarian theca, and it also increases the SHBG level. So if your SHBG levels are high, there is a greater binding of testosterone to the SHBG. So your free form of testosterone that is available will be less, and therefore the hyperandrogenic features in a female will be less. That is how it does the job. Hyperprolactinemia in this case is with normal estradiol would just be common association of PCOS is that you often find these people having slightly elevated levels of prolactin, and that is probably due to the effect of LH and androgens on the lactotropes in the pituitary. It is not very well understood, but most of people usually do have to have a prolactin level slightly elevated or even in the hundreds. And SHBG is usually lower in PCOS. As I've said, it is usually related to the obesity and the high LH levels. The reasons include that androgen reduces the globulin production, whereas estrogen promotes production. And it is a protein for transport of sex hormones in the blood. Okay, so be mindful, the patient has got triad of features, overweight or obesity, number one, hyperandrogenic features manifested as hirsutism and menstrual irregularities. If they are contemplating pregnancy, then the first line of treatment should be metformin. If they are not, then the first line of treatment should be contraceptive pills. Metformin may be added as a second agent, and the third line agent we normally give is usually anti-testosterone measures, drugs like spironolactone or finasteride or flutamide. Next question. A 17-year-old girl presents with a 4-month history of secondary amenorrhea. She has been otherwise well, but noticed slight galactorrhea from both breasts over the last 2 months. She attended menarche at the age of 13 years and has always had regular periods. So she had regular periods before. This is secondary amenorrhea. She has been sexually active for approximately 10 months and occasionally uses condoms for contraception. She smokes 5 cigarettes daily and smokes cannabis as well. On examination, she appears well and clinically euthyroid. Her pulse rate was 72 beats per minute and her blood pressure was 110 over 70 millimeter of mercury. A few investigations were done. So there is an estradiol level 129, LH is 4.4, FSH is 2.1. Prolactin level is glossary raised, is a 6,000 plus. A thyroid function, the free T4 is 7.1 and a serum TSH of 2.1. So which of the following is the most plausible diagnosis? Whether she is pregnant because she is sexually active at the moment, whether this is polycystic ovarian syndrome, whether this is non-functioning pituitary tumor, whether this is cannabis-induced hyperprolactinemia, or whether the girl has a prolactinoma. Okay, just go through the biochemistry one more time, and then you can make a choice. So answer here is E, just prolactinoma. This girl has hyperprolactinemia because she has got the features, which is secondary amenorrhea and galactorrhea, which are classical features of raised prolactin. And mostly in patients with micro or macro prolactinoma, the levels are usually in the thousands. So any levels which is more than 2000 is usually suggestive of a prolactinoma. Whether it is a micro or macro, that can be evaluated only by doing an MRI of the pituitary. You can have non-functioning tumor of the pituitary, which can compress the pituitary stalk and give rise to high prolactin, but those levels are not in the thousands. They are usually in the hundreds. And most people with non-functioning pituitary lesion will often have other coexisting deficiency of pituitary hormones. So other causes of raised prolactin, can be due to physiological stress like exercise, stimulation of nipples, sexual intercourse, and post-seizures. And drugs are also commonly associated with hyperprolactinemia, but for the most common cause are antipsychotics and antidepressants. Cannabis is given here just to deviate your mind, so don't get carried away. The drug-induced hyperprolactinemia, again, may not be that high, but this patient typically has features of prolactinoma. Although hyperprolactinemia is a feature, but this is not pregnancy, as the elevated estradiol concentration would be accompanying hyperprolactinemia. Yeah, if she was pregnant, the estradiol level would have been high. So PCOS may be associated with hyperprolactinemia due to the effect of high LH and androgens on the lactotropes, which I've told you in the previous step. So therefore, what you need, if this is a second, followed up by a second question, all you need is a full pituitary screen after that, an MRI of the pituitary, a visual field assessment, and then you have to treat the patient either with 𝒃𝒂𝒓𝒛 or 𝑨𝒃𝒂𝒂𝒓𝒛, which is a dopa agonist. So it is a two-phase question here. Number one is to make the diagnosis. The second part of the question may be, what will you do next for the patient? So ideally, even before doing a full pituitary screen, you should do an MRI of the pituitary, because if there's a micro or macroprolactinoma, you just go and treat the patient straight away. Okay, but the patient may have visual compromise if there is any evidence of macroprolactinoma due to compression on the optic chiasm. Number three, 25-year-old lady presented with 4-year history of hirsutism. So you'll see the questions on the same thread, but every diagnosis here is different. 25-year-old lady presented with a 4-year history of hirsutism, having noticed coarse dark hair under her chin. She works as an educational counselor in a university and therefore invariably finds these symptoms very embarrassing and distressing. She has tried local measures such as shaving and applying depilatory creams, but again, without much success. She attained menarche at the age of 15 years and her periods have been irregular. She has not conceived and has had an intrauterine device fitted for contraception. On examination, her body mass index was 25. She had coarse dark hair and she did not have any galactorrhea. Investigations are as follows. So please have a look through. You can see the androstenedione is slightly raised. The dehydroepiandrosterone is slightly raised. 17-hydroxyprogesterone is raised. Serum estradiol is in normal reference range. Her testosterone is pretty much normal. Plasma LH and FSH is okay. So which one of the following is the next most appropriate investigation? Whether you'll do an MRI of the pituitary, whether you'll do a CT scan of the adrenal gland, whether you'll do a 24-hour urine-free cortisol, whether you'll go for an ultrasound of the ovaries, or whether you'll go for a short synactin test with measurement of 17-hydroxyprogesterone. I think the answer here is E, which is short synactin test with 17-hydroxyprogesterone. So this patient already has got elevated level of androgens and also has got an elevated level. Hello? Has an elevated level of 17-hydroxyprogesterone, which is diagnostic of non-classical congenital adrenal hyperplasia. So congenital adrenal hyperplasia, you know, is an inherited defect of cortisol synthesis, and also it affects the aldosterone biosynthetic pathway. So if you go back to your biochemistry book using Harper, you would have seen that if there is a defect in one of the enzymatic pathway, then the whole tract gets diverted to the other ways. So in this case, the classical enzyme that is deficient is 21-hydroxylase, and therefore the whole pathway of steroid biosynthesis gets diverted to produce more and more androgens, which is either androstenedione, dehydroepiandrosterone. The classical one tend to happen in the early age group because it is autosomal recessive. So people are often affected earlier. And again, the classical enzyme deficiency is 21-hydroxylase. But the second most common is 11-beta-hydroxylase deficiency. You'll have to remember these two enzymes because they come in exam. Okay. The clinical presentation is often indistinguishable from polycystic ovarian syndrome. But in a PCOS, the patient is not going to have elevated level of 17-OHP until unless you do in the second half of the cycle. Under normal circumstances, if a woman has normal menstrual periods, if you do 17-hydroxyprogesterone after ovulation, the levels will be elevated, but not quite to the level which will be diagnostic of non-classical CAH. But this patient actually had amenorrhea or irregular menstruation. So there is no distinguishable part of first half or second half of the cycle. So any elevated 17-OHP with elevated androgens should make you think about non-classical CAH, and these patients usually don't have electrolyte deficiency. And because they respond, the adrenal gland respond to synactin test very well. Once you stimulate the gland with synactin, the 17-OHP level will be significantly elevated, and it often gets above 30 nanomoles per liter. How do you treat the condition? You actually have to suppress the ACTH drive, because it is the ACTH, because once the normal steroid pathway is impaired, the ACTH from the pituitary will be very high. And you have to suppress the ACTH to prevent androgen production from the adrenal gland. And you do so mainly by giving glucocorticoids. And you have to give them because these patients are glucocorticoids and mineralocorticoids deficient. So they should be on glucocorticoids and fludrocortisone together. And the dose is often adjusted depending on the salivary 17-hydroxyprogesterone levels. So when they come to the clinic, we do salivary 17-OHP levels, and we normally keep the level in the upper third of normal. Okay, so non-distinguishable features from PCOS, but hyperandrogenic features with elevated 17-OHP or 17-hydroxyprogesterone, the answer should be classical or non-classical congenital adrenal hyperplasia, if that is a choice there. Number 4, a 46-year-old gentleman presents with 5-month history of erectile dysfunction and reduced libido. So this is a 46-year-old gentleman who presents with 5-month history of erectile dysfunction and reduced libido. He has been married for 10 years and has 3 children. He smokes 10 cigarettes per day and drinks approximately 10 units of alcohol on a weekly basis. Examination revealed presence of central obesity with normal secondary sexual characters. So you can have a look through the investigation that was done for him. Hemoglobin, white cell platelets are all good. Electrolytes are okay. Fasting blood glucose is okay. Liver function test is normal. Now coming to the business end, that is the endocrine panel. Thyroxine is okay. TSH is okay. Prolactin is okay. Testosterone is low. LH is high, 23.3, and FSH is high. So a man who has already got 3 children, has got erectile dysfunction with reduced libido, now has got low testosterone with elevated LH and FSH. Which one of the following investigation would be most appropriate for this gentleman to confirm the cause of his presentation? So either you do a MRI of the pituitary, or you go for a testicular biopsy, ultrasound scan examination of the testis, whether you go for a karyotype, or you go for estimation of serum ferritin. So you're dealing with a hypogonadal man, and I've already shown you the biochemical picture. So the answer here is actually C, which is ultrasound scan of the testis. So as you can see, that the biochemistry is reflective of hypergonadotropic hypogonadism, which means that it is the testicles that is at fault. So it is a primary gonadal failure. And because the testicles are not producing adequate testosterone, the pituitary is throwing in loads of LH and FSH into the circulation. Had it been a hypogonadism due to pituitary cause, then you would have had a low LH, a low FSH, and a low testosterone. So primary hypogonadism would suggest a hypergonadotropic hypogonadism, whereas secondary hypogonadism, which is due to pituitary cause, will have low level of LH, FSH, and testosterone. And more so, primary hypogonadism is most likely to be associated. So if the problem is within the testicles itself, you will have not only low testosterone production, but also low sperm production. Although many testicular disease damage both the seminiferous tubules and Leydig cells. In contrast, as a consequence, in contrast, if it is due to secondary hypogonadism, your sperm production and the testosterone production may be often proportional. The common cause, so this man has had 3 children before, so whatever that has happened has been an acquired cause which has happened later. And it could be anything. It could be a trauma to the testis. It could be an inflammation of the testis like epididymoorchitis. It could be a testicular tumor or infiltration. So most appropriate investigation here is to evaluate the size and architecture of the testicles itself. And therefore the ultrasound will be ultrasound, and the answer will be ultrasound scan of the testis. Ferritin is here mentioned because ferritin deposition in the pituitary due to hemochromatosis can lead to hypogonadism. But in those circumstances, the LH and FSH would have been low. The karyotype is mentioned because Klinefelter syndrome is a common cause of hypergonadotropic hypogonadism. But since this man has had 3 children, he can never have Klinefelter syndrome because those patients are usually infertile. So karyotype cannot happen. So the common causes that may happen due to primary or congenital hypogonadism would be, of course, Klinefelter syndrome, mutation FH and LH, cryptorchidism, varicocele, myotonic dystrophy. And there may be some acquired causes which I was mentioning, mainly infections, radiation damage, chemotherapy, glucocorticoids, trauma, or the testicles will undergo torsion, any systemic illness, autoimmune disease, or any systemic major illness affecting the liver or the kidneys. So just be mindful that where is the lesion? If you see LH and FSH are elevated, usually it is primary gonadal failure. And if it is LH and FSH suppressed, it is usually secondary gonadal failure due to pituitary disease. So this is a 31-year-old lady who presents to the clinic with amenorrhea for the past 4 months. She has also suffered a loss of libido and problems with sexual intercourse with her partner. So this is a lady, not a man. There is no other past medical history of note, and she does not take any other medication. On the examination, her blood pressure was 120/80, so she was normotensive. Pulse rate was 72 beats per minute with a body mass index of 22, so she is not even obese. Hemoglobin level is okay. Leukocyte count is okay. Platelet counts are fine. Electrolytes are fine. Sodium and potassium. Creatinine is okay. FSH is elevated, 38, but prolactin is 597. Her pregnancy test is negative. So which one of the following is the most likely diagnosis? So she's 31, she has lost her libido, she has lost her sexual intent, but she's normotensive with a normal BMI. So whether this patient has a prolactinoma, whether she's got a non-classical congenital adrenal hyperplasia, whether she's got hypopituitarism, whether she's got polycystic ovarian syndrome, or whether she's got premature ovarian failure. Just focus on the biochemistry, what is normal, what is abnormal. So the answer is actually E, which is premature ovarian failure. The FSH, or the follicle stimulating hormone, above the range of diagnosis of menopause suggests premature ovarian failure. So she has got all the features of estrogen deficiency. She has got low libido, she's having difficulty in having sexual interaction with her partner, but she's normotensive and she does not have any hyperandrogenic features. There is nothing mentioned in the biochemistry otherwise that would suggest a PCOS or I have not mentioned any androgens or anything, or any abnormal electrolyte levels. So the only abnormal thing there was an elevated FSH. Prolactin is a stress hormone and it can be elevated in any condition. And it was very mildly elevated. So if it is a premature ovarian failure, the most sensitive indicator is elevated FSH, but people may also have elevated LH and low level of estrogen. So this is most.
Sir, what about hyperprolactinemia?
So patients should be counseled with respect to, because this is a young woman, so it is significantly will have a psychological impact if there is premature ovarian failure. So they should be counseled properly, and therefore appropriate hormone replacement treatment should be considered, because not only to provide them with sexual health, but also to protect their bones, because they will be very prone to osteoporosis.
Sir, what about hyperprolactinemia? Answer hyperprolactinemia for this question.
Hyperprolactinemia is only 590. So this is not indicative of anything. There is no mention of anything in the stem, whether she has got galacturia or whether she has got any other features of hyperprolactinemia. Okay?
Okay, sir.
Prolactin is a physiological, it can give rise to, it can be rising because of physiological condition. As I've said earlier, if the levels are 500, 550 or 60, they're often due to physiological conditions. And there is no mention of anything to suggest that she has got PCOS. There is no mention of testosterone levels, no mentions of elevated BMI. She's normotensive, so there is no features of hyperandrogenemia